Just so we get a sense of the probabilities. Couple of basic points. You all know this. We have an overrepresentation of juveniles who come into contact at all points in the system of mental health and substance use disorders, and the deeper you penetrate into the system, the higher the prevalence tends to be. And at least in my world, the deepest end of our system, the secure treatment facilities that are operated by our juvenile justice authorities, if you look at the case histories of these young people and you compare them to the state hospital unit that is run for adolescents, you'd be hard pressed to figure out by what rationale this particular body ended up in this box and this particular body ended up in that box, except that there's kind of this random card sort of which judge you got, which probation officer you got, whether they saw you more as a victim, whether they saw you more as a perpetrator, and quite frankly what your gender is and are you of color. With the research very clear that adolescent males of color with very similarly situated histories tend to get gravitated towards juvenile justice to tee them up for criminal justice, and females who have behaved in roughly the same ways but are not of color tend to get gravitated towards mental health. So one of the things we have to sort of think about is what is this funnel that is operating that tends to drive kids into a system, and what are the characteristics of that system. And there are many of us who think that the research pretty clearly would support the notion that juvenile justice is increasingly kind of the default forensic mental health authority without anybody standing up in the legislature and saying what we're creating is a forensic management system for kids with mental health issues, substance abuse issues, and as we'll see, most of them co-occurring disorders. And we're simply replicating on the juvenile side what we have done over the past half century on the adult side since the mass deinstitutionalization of people from state hospital systems on the adult side, with the promise of a flexible continuum of care based in the community that would be adequately funded. So we did the lovely job of getting people out of the hospitals, but we never built the system that was intended to receive them. There are many of us who sort of say the data is pretty much clearly showing that we were successfully replicating that bad idea on the juvenile side. And so some of the things that drive you to being here actually, I think, are intended to deal with that. So one of the things that we need to be mindful of is that we want to be thoughtful about sort of how we play the poker game. Most kids who come in contact with the juvenile justice system do not become frequent flyers. The modal number of contacts of a youth with the juvenile justice system is 1. It's the most frequent one. So we don't necessarily want to over-intervene with kids. We want to identify needs and get them served, but we don't want to over-intervene with them because there's also research that suggests that there are negative sides to formally identifying a kid as a delinquent, for example. So we've known since the 1940s that there is a measurable labeling effect of simply officially designating kid as a delinquent. It increases their risk of coming back. So the question is, if most kids sort of have their glancing blow with the juvenile justice system, and most kids are there for a drug possession crime or a property crime or a minor crime against a person, not a serious crime against a person, who are the kids that keep coming back? Who are the kids that fail to sort of incorporate what most kids get, which is sort of the social learning effect of having become court involved, however briefly, and they say, well, it was bad enough just having my mother wondering where I am, and the more I behave this way, the more adults start wondering where I am and what I'm doing, and this doesn't seem to be a good strategy for me. So who are the kids that are most likely to be most impaired in social learning strategies? One group of kids will be kids who are cognitively limited and they don't do well with social learning generally, and the research suggests that over time we're getting more and more kids with serious learning disabilities and cognitive disabilities into our juvenile justice system, to the point where my juvenile justice colleagues will tell me that a lot of the strategies in their facilities that were devised for intervening with youth, which are basically social skills, judgment, all this sort of stuff, and verbally mediated in groups, they're having a hard time now because of the serious learning disabilities and cognitive disabilities that are beginning to silt up their facilities. We used to think that kids who went into juvenile justice we're sort of roughly in the low average IQ range. That appears to be dropping over time. So we have one group of kids who have serious learning disabilities or cognitive disabilities who are failing to do social learning like most kids. We have some group of kids whose capacities for that are disrupted by mental illness. We have some group of kids that are disrupted by their pattern of substance use, which is not helping them sort of figure out what they need to learn by these glancing blows. And we have some group of kids where we're watching them in some sort of family context or some peer culture context where the glancing blow is not having the desired effect. So I have certainly worked with kids where, to be honest, they just don't have any street cred until they have been arrested and done a little time. And so sort of threatening to lock them up is not exactly going to deter them because they need that for their sort of portfolio. And the most complicated kids are going to be kids who have some combination of these that complicate the social learning process. So if that's who we've got, and they tend to be kids with multiple problems and they tend to penetrate, we have to kind of look at features of them and features of the system. So if there are kids who are having difficulties because of learning barriers, learning challenges, what's the quality and accessibility of special educational supports? If we have kids whose capacities are compromised or complicated by mental illness or substance abuse, what are the kinds of access challenges for them, and what is it that they get when they get there? Are important questions. Are there ways to disrupt peer culture? And we know that, for the most part, congregating delinquent kids into groups for long periods of time actually has the opposite result that we would hope, which is to ordinarily reinforce attitudes, values, and beliefs that are consistent with continued delinquent and then criminal behavior as they age into the adult jurisdiction. So just as a poker game, just looking at the probabilities, I think it's astonishing, actually, that a variety of studies done in different places and at different times are coming up with roughly the same kinds of numbers about kids having mental health disorders, diagnosable mental health disorders in the juvenile justice system. And I also think it's instructive to sort of look at what the overall picture is for young people. So about 2/3 of males, but a higher number of females having met criteria for at least one disorder. I think this is a really interesting split, particularly when you appreciate that the trauma-related disorders will sit in the anxiety disorder box. My guess, actually, is that this is low. And that's partly going to be an artifact of how we do diagnosis in adolescents and children for trauma-related disorders. We don't have a good diagnostic scheme for that. This is pretty impressive. I think, actually, since you would think that the kids in the juvenile justice system would be there for bad behavior, the fact that less than half of boys and just about half of girls would meet criteria for disruptive disorder is instructive. And it sort of makes you wonder, and the research would actually bear you out, that in many cases people are icing kids in the juvenile justice system in an effort to access services or to try and keep them safe while people sort of figure out what to do. But if there were some other option, they would choose it. In most jurisdictions, there are precious few places where you can send a kid with high needs, especially where the people can't say no. And one of the places where you can send them where they can't say no is the juvenile justice system. Substance use disorders. Conduct disorder would be in that category. And substance use disorder. I also think what we're needing to look at is that we have more than half of them, just slightly more than half, meet criteria for at least 2 diagnoses, and about 6 out of 10 will meet a co-occurring disorder diagnosis. So if I just take 100 kids and I know nothing about them, just playing the card game, I know that I've got a pretty high need group of kids, and I know that more than half of them are likely presenting with a co-occurring disorder. The question is going to be how to identify those kids using screening and assessment, and how do I sort of think about them as potentially being in multiple boxes at the same time, which is one of the reasons why I really liked the Detroit model of when they get their kid into their assessment unit, they are given a variety of assessment tools that include cognitive testing and emotional testing and screening for substance use and a variety of other things. And I think you are probably one of the first jurisdictions to document the number of kids who come into contact with the juvenile justice system who have not been identified for special ed needs, but in fact would meet criteria for them. My guess is that we've got lots of kids that sort of float through our system, and if we don't like flip the rock over, we're not going to catch them. And believe me, I respect, admire, and even deeply love our colleagues in education, but there are perverse disincentives in school systems to identify kids who they then become responsible for serving. And like the small print at the bottom of the advertisement says, individual results may vary, and I have seen school districts who have worked very hard and quite capably to identify kids with needs and then serve them, but quite frankly, I still live in a world where I see kids who make it to their junior year of high school and they're still reading at a third grade level and nobody seems to have noticed the kid has a 55 IQ. He just isn't throwing a chair, so he doesn't get picked up for his needs. We also have some data for the proposition that in the absence of ready access to care, the juvenile justice system is the default box for kids who have urgent health care needs. And at least with some of the judges that I spend time with, they will tell you after hours that if they're worried about a kid and their mental health needs, at least they know when they go to our detention facility they'll be safe until they come back, sort of the way that they think about it. So you can look at these, but I just think these are nice little snapshots of data points. One of the sad stories, actually, although I think is illustrative of the situation in which some families find themselves, was a parent of a young man with some pretty significant mental health needs who had difficulty accessing services, and he and his parents would sort of have these high levels of conflict. Sometimes they got physical and police would respond. And the police were actually in a jurisdiction where they were very well trained, they were very sympathetic to the problem, and they eventually tired of the sort of frequent flyer to this one house with a mentally ill kid. And the police officer told the mother one night when they had responded, okay, here's what's going to happen. Because your kid is a mess, and I don't know why the emergency room won't sort of pass him on for services, hospitalize him, whatever it is. I don't know what they think they need for criteria, but this is not a good situation, so I'm going to get back in my cruiser. I'm going to go park 2 blocks away. You're going to take $20 out of your purse. You're going to leave it on the counter. You're going to go for a walk, and when you come back and that $20 is gone, you're going to call me, and I'm going to come back and I'm going to arrest him for theft, because this is the only way that we can get your kid's services. The first part of that was true. They could take him into custody. What services he was going to get is sort of this $65,000 question again, once he enters a system that is not specifically designed for dealing with deeper end kids. So these are all places where you can build in screening and assessment capacities. What we're learning is that for youth who really don't need to penetrate the juvenile justice system, it's probably better if you can back this up as much as you can. But it's also worth remembering how all of this looks from a kid's point of view. So we know that one of the periods of high risk, for example, for suicide, is in the first handful of hours that when a child goes from the street into a detention facility. We sometimes lose sight that the next highest risk period for kids to commit suicide is in the handful of hours or a couple of days before they're released from a juvenile incarceration setting. And from their point of view, for some of them, the secure placement, either in a treatment facility or a juvenile incarceration facility or in detention, is a momentary hiatus from insolvable problems on the street. And we think we're doing them a favor by letting them go. They're just going back to the trouble that they left and the problem that they couldn't solve in the first place. And if the desperation is high enough, That's another place. So we're often very focused on screening when they first come in. We need to be thinking about screening as we're having them exit out, especially if we might have been providing them an island of safety and continuity. So just rapidly distinguishing between screening and assessment. Screening ideally is universal. It's at a point of contact where every kid who has that point of contact will get the screens that you've chosen. We'll talk more about what you have found and what I might advise you to think about by way of using standardized and research-validated tools. I am not an opponent of homegrown tools as long as they are followed up by a validation procedure. And some of them you may want to think about depending upon the populations that you have. So if you have particular populations in your jurisdictions that are not well represented in validation samples for the commercially available and research tools, you might want to think about whether or not it's worth doing something in particular to match the linguistic or cultural needs of the populations that you've got. If, however, you have folks that are within the kind of ordinary comparison samples of the research-validated tools, then it's probably easier just to take something that looks like a good match for your population and then use that. I have program folks here. Do you want to comment on that? Thought?
Well, a lot of the people we work with use tools that they create. I don't know how they create them. This is a good question. This is a good question. Let's just ask that. And can tend to be reluctant to have those screeners or assessments examined by anybody because they work for me. Don't tell me what I should be asking our kids. So if you can show them the benefit of a more rigorous evaluation of what they're doing, they tend to hop on board with that. As long as you're not trying to change what they're doing with the kids they work with.
So a strategy that I have found effective when people are reluctant to give up the tool that they have developed and it's sort of like their own homebrewed little tool is to at least pair it up with another one so that over time they can see what they're finding may match up with a validated tool. The other example that I like to give them is from medicine. Because this is a great example of how you can get better outcomes by sort of arriving at a consensus for a screen. So about 10 years ago, 12 years ago, people who were interested in the outcomes of folks showing up in emergency rooms with chest pain realized that the evaluation that somebody got for chest pain largely depended upon the emergency room that they went to, where their doctor was trained, when their doctor was trained, and whether or not they had somebody who could serve a triage function in the form of a triage nurse, because not all emergency rooms have a triage nurse. Smaller hospitals, community hospitals, rural hospitals may not have the density of staffing to do that. And what they found was there were huge variations in who got identified as having a heart attack or not, who was admitted for further testing or not, and who got admitted because they thought the person was actually in some danger of active heart attack. And they found huge disparities in recovery and death rates. Now if you go into an emergency room in the United States and you are complaining of chest pain, you will be asked exactly the same 7 questions. Because it turns out that the answer to those 7 questions are very sensitive to whether or not you are in the middle of having a heart attack or if you have simply had a bit of bad cheese. Okay? And on the basis of answers to those 7 questions, they will then advance you on for further assessment and possibly admission. So sometimes using examples that are out of medicine where we sort of do screens and sort of ask them, would you want the pediatrician for your child to be using an assessment procedure on your kid that they just happen to make up because it seemed to work for them? Or would you want them to use something that appears to be a fairly standard and validated approach that almost every other pediatrician in the country is using? If they can't buy that, then I think pairing them up with something, if they're willing to do that, some other kind of validated tool. Most of the screens are readily used by non-mental health professionals and identify youth for further assessment. That first point, readily used by non-mental health professionals, I actually encourage folks to incorporate screening by non-mental health professionals, at least in part, because it gets people kind of familiar with the tools, familiar with the issues. If you can get, for example, probation staff or non-mental health intake staff to begin using the tools, it often helps break down the bifurcation that sometimes exists between roles. Oh, that's a mental health thing. And in fact, that doesn't work as well as people sort of working together and collaborating around a common vocabulary. Now, this is one of the other sort of complicated questions because you will either widen your net or drop your net depending upon where you set your thresholds for referral for assessment. Sometimes that will be a function of just who you want to identify. Sometimes, to be honest with you, it'll be a function of what your capacities are. So if this sort of thing works best when it's timely, when assessments are timely and when assessments are reasonably sophisticated and individualized. But if you only have one or two assessors and once you screen a kid in, it's going to take them 8 weeks to get the report back, that's not a particularly helpful feedback loop. So you may want to be thinking about what your capacities are, what your continuum of care is, because we don't want to either under-intervene with kids who need intervention. We also don't want to over-intervene with kids. That's a waste of resources, and it actually often has a negative outcome. Just as a sheer, this is a little trivia question. There actually is, how many of you are mental healthers? Okay, I am also a mental healther, so I sort of toss this out. It seems to me that if we can use our powers for good, perhaps there are times when we might use our powers for evil, or we would have inadvertent side effects, just like a medication might have an inadvertent side effect profile, right? So there actually is a research literature on the negative outcomes of exposure to psychotherapy. Does anybody happen to know how many people, what percentage of persons referred for psychotherapeutic intervention have an adverse outcome even when the psychotherapy is appropriate, well-matched to their needs, and competently provided?
10%?
It's about 10%. The literature actually goes up to as many as 16%, but that bandwidth between about 10 and 16% is pretty reliable. So one of the things that I think about is I've had to have conversations with my mental health people who would routinely write down in reports, refer for counseling or psychotherapy, right? Like, what's the downside? A little counseling, what can hurt? Well, if 1 out of the 10 that you refer for psychotherapy are actually going to be made worse by it, you may want to ask yourself, is this a kid who is so low on mental health needs and so low on criminogenic risk that 1 out of 10 is not a good bet for this kid? Because it's not a zero-sum game for your lowest risk, lowest criminogenic need kids.
Yeah, I was a little surprised when David Demora this morning suggested that the group 1 on that chart should be referred for mental health services.
I would be surprised. I'd want to know, again, sort of if they're low, what are we treating? And what's the modality that they're going to get? So, if they've, I think of it as the upholstery on my car. How bad does the tear on the upholstery on my car have to be before I take it into the shop to do it? Right? I can live with a lot of little tears in my upholstery before I'm going to go drop $1,000 for them to put new plastic on my seat. And unfortunately, for at least a certain percentage of kids, it's going to be not a good thing. So at least it's worth thinking about what the balance would be.
But there's no benefit for your upholstery not being in the shop. Whereas low risk kids, there's some benefit for them being on the football field or with their pro-social friends, rather than sitting with a psychotherapist.
Or dealing with the stigma that many of them get by going to therapy. Oh, yeah.
Well, and here's the other little fly in the ointment. Suppose this low kid doesn't go. And now you've got a violation of probation, and you march this kid who probably really didn't need to be there in the first place down the conveyor belt into the next level of the system, where you probably should have been able to sort of, release. So the screening, we'll talk about tools in a moment, but this is really kind of your first set of questions, and this is a really important question to be defined in terms of your capacity and what you're going to link it to. Because screening is not particularly helpful except for data collection and advocacy purposes unless you've got something to send them to, which is the question that should be identified by assessment. So assessment is ordinarily going to be done by a mental health professional, especially if we think we're dealing with folks with mental health disorders. Tends to be, should be individualized. It's more time intensive. And one of the questions that you need to ask yourself in developing your assessment capacity is, what are we assessing for? And how does that sort of overall fit into our system? So our friends in Wayne County, Detroit, have a feedback loop so that when they identify a kid with an SED that would qualify them for special ed, they've got sort of a way of bringing this to people's attention for a response. If it's just going to sit in your file, hard to know what that's going to get you. And so whatever it is you're assessing for, you need to sort of think strategically about how you then respond to the results of your assessment. Here are some of the challenges that you'll want to be thinking about in setting up your assessment capacity. For many years, the world of mental health and substance abuse have been siloed. And there are many mental health professionals who are licensed and capable who are not particularly well trained in the identification and the assessment of substance use disorders. There are many people who are licensed as substance abuse counselors who are not particularly well trained in differential diagnosis for things like depression or anxiety disorders or other stuff. What you're looking for, given the high rate of co-occurrence in your assessors, are people who have their feet in both of those worlds and who can think in sort of interesting and complicated ways about relative contribution and who are prepared to not know. Because I can tell you, having spent much of my life doing these kinds of assessments, there will be a lot of times when I will say, I've got this piece, I've got this piece. I don't know yet what the relative contributions of these two are. And I probably won't know until this kid has been clean of drugs or alcohol for some period of time so I can see what the residua are. So you want people to be sort of clear about what they see and they don't see, but you also want people who are prepared to be modest and not necessarily tell you, I've got all of this kid entirely figured out. The other thing that you're going to want in your assessors are people who are trained to distinguish between two overlapping but distinct concepts. One is rehabilitation, the other one is treatment. Most mental healthers are trained to identify targets for intervention in the form of treatment. Treatment can sometimes support rehabilitation, but treatment does not necessarily get you to rehabilitation. So, for example, one of my very, very favorite kids, who's now a young man and doing quite well, I'm happy to say, was a young man who was very, very gang involved in the neighborhood where I lived, actually. When he wasn't locked up, I used to see him walking down the street, we'd say hi, exchange pleasantries. And he was very invested in the illegal handgun and drug trade in our neighborhood. And he was really quite skillful at it. He was a kid who had sort of surveyed his situation and figured that in his world at the time, since he figured he was going to be dead or in state prison by the time he was 25 anyway, why not have a good time and make some serious scratch on the way, right? That's sort of how he viewed the world. So unfortunately for him, he was also just riddled with genetic predisposition for recurrent serious depression. And so even by the time he was 14 or 15, when he would have depressive episodes, he would first go through this phase of pronounced irritability. And I don't like irritable people who are packing heat. That's just sort of a bad place to be in the world. And when he passed through the phase of irritability, he would become pretty disabled by the depression. He would literally not get out of bed for days at a time. From a public safety point of view, having him at his most acute and depressed was a good thing, because when he wasn't getting out of bed, the streets were safer because he wasn't there. You treat his depression, you bring him back up to his usual gang-involved, entrepreneurial little self. So treatment for his depression did not solve the problem of rehabilitation, which is the broader concept, which is roughly what judges are asking us, like, so what's going to happen that this kid doesn't come back? You absolutely need to treat his depression, at least in part because he can't do social learning when he's sitting in bed for 5 days at a time. On the other hand, you certainly don't want him going through that irritable phase into his incapacitated phase, because you don't want him armed and on the street in potentially volatile situations when he's having that sort of sharp irritability driven by his depression. On the other hand, we wouldn't want to confuse treatment with rehabilitation. So when you're having people do your assessments for you, you're going to want them to be able to think about different kinds of boxes. And the different kinds of boxes are not things that they will ordinarily have been taught about in their training. One box is the kid whose difficulty seems to be largely, if not entirely, driven by the mental disorder or the substance abuse problem. So let's imagine a kid who is really, really irritable, like my other little customer, but when he's not, and he's getting in fights at school. Right? And you look at his history and you see that when he's not getting acutely depressed with the symptom of marked explosive irritability that many adolescents show when they get depressed, he's actually pretty much of a standard issue adolescent with no problems than most. You have the feeling with this kid, based on his history, which is what assessment has to get to as part of it, you have the feeling if you adequately treat his depression, his irritability will drop, he will be less reactive, and he'll just go back to school the way he has for most of his life. Then you have other kids where you have the feeling that the mental health symptom is exacerbating something to which they are already predisposed. So if you've got a kid who's coming in and he's already a fighter, and he has been for a long time, and he really doesn't mind getting into people's faces, and he gets markedly irritable because he's depressed, you treat the depression, you're just going to get him back to his baseline, right? His kind of in-your-face, scrappy baseline. And then you have some kids where you have the feeling that the mental illness is there, or the substance abuse is there, it needs to be treated, but it's not what's driving their problems with the world. And I have certainly seen kids who, for example, have a substance use disorder. They're smoking a lot of marijuana, but nobody who knows them well has this fantasy that if you get them to stop smoking marijuana, they're going to also stop stealing cars. You want to treat the marijuana problem because that will compromise their capacities for social learning. It will continue to bring them into contact with illegal behavior, all this sort of stuff. But that's entirely different from the rehabilitative mission that we'll have to carry on a separate track. I see lots of really good mental health reports that are done as assessments where nobody has parsed that picture out. And I think if you're going to get assessors, you're going to want to make sure that they can use the data that they rely upon to help you figure out which of these sort of boxes on the continuum that you've got. You're also going to want somebody who is knowledgeable of the juvenile justice system, that they know what you can and cannot do inside of the juvenile justice system, the treatments you can and cannot provide, the treatments that do or do not exist in your community that may be well matched for a kid. And you also have to, I think, look at cases very carefully and teach your assessors to look at cases very carefully to see whether or not you have had a kid who has had intervention but not the right intervention, and has had the right intervention but has not responded to it. So how many of you have seen those kids where the case file comes in and the kid seems to have been in some sort of psychotherapeutic or mental health intervention since in utero? Like you're sort of like wondering, how do they get the little couch in there anyway, right? And often these are kids who are identified relatively early, and by the time they're 10, 11, 12, they've been identified by special ed, they have clear histories of sort of behavioral discontrol, They often have histories of aggression that date to preschool, and you look at them at 12, 13, 14. At least in my state, if we're going to think about the juvenile court judges in our state for everything except murder, 14 years of age and above, everything stays in juvenile court. Our juvenile court judges for kids who've done serious things, who are called youthful offenders, have the authority to sentence kids to state prison. One of the factors that they're required to look at is whether or not a youth indicted as a youthful offender and convicted on a serious charge has responded to efforts to rehabilitate or to intervene. Right? And you look back at what a lot of these kids have had, especially the kids who have had sort of persistent aggression since preschool, and you look at the child therapy interventions that they have had, and none of them have a shred of evidence that they work with persistently aggressive kids. So should my judge think of that kid as an untreated kid? Dial it back, no intervention? Or should my judge think of this kid as a kid who has failed out of intervention? Although nobody who knows the literature on the intervention would think there was a ghost of a chance of this ever working. So in individual cases, this difference can have huge implications for how people think about this. So please have them be thinking about what you have available in the community, whether it's exposures that we would hope would be effective, and to sort of bind them up. Let me just say one other thing, and that is because of the very high prevalence of trauma and our very poor psychiatric nosology for characterizing trauma in children, your assessors have to be particularly good, in my view, of bundling the usual mental health disorders, the substance use disorders, and trauma exposure, because I see lots of kids who are not going to meet the criteria for PTSD, and we are not yet in a world where DSM acknowledges what people sometimes call complex trauma or developmental trauma disorder. And if you're looking at that kid through that lens, it could not be clearer what this kid is looking like, and the reactivity to and adaptations that they've made to their trauma history. And you see a really interesting thing happens, and your assessors should look for this also. Kids who have incredible trauma histories, they've been in the child welfare system, all this sort of thing, but they never met the criteria for PTSD, so it never got in there, and sometimes even if it did. But by the time they hit 13, 14, 15, and they start looking more scary, the trauma component of their history drops out and is replaced by conduct disorder. And we know that there is a literature that suggests that the diagnosis of conduct disorder is subject to a lot of diagnostician bias. Likeable kids don't tend to get conduct disorder. Annoying, scary kids tend to get it, regardless of the objective features of the kids, and kids of color are more likely to get it. Just like as adults, persons of color are more likely to get an antisocial personality diagnosis. And I don't think people are waking up in the morning and say, I can't wait till I misdiagnose a few people today. I think this is all, sort of important stuff. And if diagnosis really matters, you should be using a structured diagnostic tool anyway, because the research literature on unstructured clinical interview to render a diagnosis suggests that on a good day, it's almost random, depending upon who your examiner is. So so the last thing I want to say, and then we'll go back to your comment, is your assessors should not be focused on diagnosis. Your assessors should be focused on functioning. Whatever we call it is less important than characterizing its impact on functioning and where this kid's baseline is. You had a comment at the back, a question?
In terms of the conduct disorder, it does sound like we overly diagnose that. I guess we're so quick to want to give a diagnosis and call it something. So perhaps we can get the kids some services, because that's the only way to do it. But I hear you saying really that it's not necessarily that, but a traumatic event in time that perhaps is bringing out this particular behavior in this kid, and we really need to look at that closely.
Or contributes to something that we're sort of concerned about. So what I would say is the literature is also pretty clear that most kids who experience adverse incidents don't actually become traumatized by them. There's a continuum between stress, distress, adversity with adaptational challenges, and then people who are traumatized. Literally, the neurobiology of their bodies is overwhelmed by the stress to which they have been exposed. Your assessors should be able to characterize a kid on that continuum. Not all kids who have been exposed to stressful or distressing events are forced into adaptations or are overwhelmed by them. But if they are, we still have to sort of ask, since most kids who have exposures to traumatizing events do not go on to perpetrate trauma on other people, why, what is it about this kid that what extra is there about this kid that led this kid down this trajectory when most don't? What additionally sort of compromised their functioning or drove them in this direction? Or what didn't they get that most kids who are traumatized do get that serves as a protective factor from them sort of wandering down that road? Okay? So if I've got a kid who's conduct disorder and has a high trauma history, and one of the features of this kid's high trauma history is he's very easily or she's very easily emotionally dysregulated, and when the emotional dysregulation goes, they've got the attitudes, values, and beliefs that tell them it's okay to solve my problem through threatened or actual violence. That's two different things. Because there's going to be a lot of kids who are emotionally dysregulated and they don't attack other people, right? When they get emotionally dysregulated. They may punch a wall, but they won't break your jaw, right? Or a lot of them actually are more at risk of hurting themselves than at hurting somebody else. So the emotional dysregulation is part of what's driving this, but the sort of attitude, values, and beliefs that tell me it's okay to solve my problem by punching your lights out is a different problem. It's the cognitive overlay. It's what I think of in military terms as the rules of engagement, the target acquisition rules about against whom is it permissible to engage in certain kinds of violence at certain levels of intensity and for how long, which is a separate problem than the emotional dysregulation. And most of them actually, if they're going to go in a direction, they tend to be self-harmers, although we're learning that a lot of the stuff that emotionally dysregulated kids do serve much the same function. So a good assessor would sort of say, for example, this is an adolescent boy who punches out walls. Now, if I were to say this is an adolescent girl who's cutting herself or burning herself or purging, we would sort of say, oh, we kind of get this now. We know what this is. We know that this is an effort at a high-intensity experience in order to re-regulate intolerable affect. If it's a boy punching out a window, we're not so quick to go there. Although if you look at the histories of the boys, the exact same behavior, they will talk to you also about sort of an intermounting sense of tension that they can no longer handle. They dysregulate. But instead of going into the bathroom and throwing up or cutting themselves, they get in a high-intensity encounter with another individual, or they almost, they'll break their hand by punching a cement wall. And then we're sort of looking at that at the box of sort of aggressive criminal behavior, especially if the target is a person or a valuable piece of property, without sort of understanding that they've got this other thing going on that in a slightly different context seems very, very familiar to us. So your assessor has to kind of be thinking through these various lenses and being very precise in describing functioning. So one of the things that I torture my students with, just because I love to torture students anyway, which is, if I couldn't find this, I would have found something else. What does it mean when you describe a kid as impulsive? How many of you have seen reports where kids are described as impulsive or having poor social skills? What the hell does that mean? Just sitting off the top of my head, I can think of 7 different things that the word impulsive can mean, ranging from, as the outside observer, that seemed fast and I didn't see that coming, although it may have been a rapid behavior that they've been planning for a very long period of time, to at the far extreme, kids who are so frontal lobe injured that there's nothing between midbrain and behavior because their frontal lobes are just way too damaged. And then you've got kids who don't think about it at all, right? And then you've got kids who think about it, but they misweigh the risks and benefits. That's pretty adolescent. And so how many of you have dealt with these kids who are described as impulsive, and really what was going on was it seemed worth it at the time. That's a different clinical problem than a kid who's got no stuffing between midbrain and behavior. Or I thought I was going to get away with it. Right? That's a different cognitive attribution problem than a kid who thought it was worth it. Right? So your assessors need to sort of sit back with the data that they've got and help characterize a young person in terms of their functional characteristics, some of which may correlate neatly with diagnosis, but if they don't, you don't want to shoehorn the kid into a diagnosis. You want to focus on the functional description. And because you're in a juvenile justice context, you want your evaluator to be playing connect the dots between the functional presentation of a young person that they're assessing and the behavior that the rest of the world is worried about. Simply getting a report back that says this kid drinks too much is like, yeah, well, okay. So do most high school juniors on any given Saturday night. But why is my kid ending up in other people's cars and trying to hit the policeman? I mean, even most drunk kids know better than to take a swing at a police officer when they try and break up the beer party, at the ball field. Yeah.
I was just going to add the complexity for people in the community mental health system. The diagnosis drives the funding. And so you're caught with the system for Medicaid in particular. You have to have this diagnosis.
If you need to give a diagnosis in order to access, then you pick the best box that you've got that describes most of what you have. But they're not going to read your report. They're just going to say, okay, this diagnosis showed up. So if you've got a kid who has depressive symptoms, I have no problem with describing the child's depression. But in this particular context, your assessor should say, these are the symptoms that the child has that would warrant a diagnosis of fill in the blank. Mood disorder not otherwise specified, depression, dysthymia, whatever you think, swings your boat. But the report that goes back to other people and to the court should say, and this is the way in which the depression does or does not interact with the behavior that brings the child before the court, and this is what we would reasonably expect from an intervention that was effective. Is this going to make my otherwise good citizen kid who's irritable because he's depressed a good citizen again? Or is it going to get my little gang guy back up and running so he can continue to carry drugs and firearms around his neighborhood? It's not helpful in a juvenile justice context to stop at the functional description and the diagnosis. You've got to go that bridge further to discuss how it does or does not contribute to what ails you.
So, what you're saying makes a lot of sense to me as someone who's worked in the juvenile system forever. But I'm thinking that our evaluations don't do any of this stuff that you're talking about. And I don't know the court would know what to do with it, or we'd know what to do with it if it did. So it occurs to me that maybe the really critical piece here is that we have a system where the service providers and the evaluators are speaking the same language, and that we're making that link, right? Because what juvenile justice, what juvenile court can do is a fairly, it's not really a scalpel, right? It's a fairly blunt thing. Kid's going to go to a residential program or he's not, or if he does, what broad kind of residential program might he go to? But the person who's actually delivering that treatment seems to me that that's very, what you're talking about might be very significant. Is that?
Yeah, well, what I'm saying is, so for my first kid who is getting in fights in high school because he's depressed and he's irritable, but that's not sort of who he is, I'm putting him in this box. Low criminogenic risk, low mental health needs. If you're going to supervise him at all, Don't over-entangle him in the system and consider the risks associated with labeling and with system contacts while you're devising that. My other kid, when he is, he is a high criminogenic risk, so I've got to decide whether or not his particular course of depression is frequent enough and severe enough to decide whether he is in one of these boxes. So it would be a waste and probably dangerous to enroll my first kid, in something like MST. It would probably not be particularly effective to look at my second kid and say, what this kid needs is a referral to somebody who's good with cognitive behavioral treatment of depression and a psychopharm consult. Because that will treat the depression, but the depression isn't what's bringing him before the court. It's the gun running and drug trafficking, which doesn't respond to cognitive behavioral treatment of depression. And so I might want to say, this is a kid who is sufficiently high on the criminogenic risk that I'm going to want to refer him for an intervention where we have evidence to suggest that it actually hits on criminogenic risk, not just on depression. So I think we do have a way of thinking about it where a court or a social services agency can take that information and begin sort of saying, where are we on this continuum, and then assigning treatments to them. And the report, and quite frankly, if you don't have one of those in your community, then you would have to say, okay, it would be lovely if we had MST or FFT or therapeutic foster care or something available. We don't have it. But and we can probably treat this kid's depression, but let's not fool ourselves into thinking that treating his depression is necessarily going to result in a change in his criminal misconduct, unless we figure out what does he need by way of the social learning process that allows most kids to self-desist over time.
Have you identified any instruments that might help evaluate criminogenic risk in this school?
Yeah, there are several sort of risk instruments. This was really all about mental health and substance abuse screening and sort of co-occurring. I happen to like the level of service inventory, case management level of service inventory, partly because it is normed on adolescent offender populations, and it's research-based in terms of the risks, the protective factors, and needs, and it drives you to identify individual responsivity characteristics. Now, here is something that I would sort of toss out for you. That tool and a couple of others allow for what's called an override at the end, where in the individual judgment of the assessor, you can either increase the risk, and you have to write your reasons down, or you can lower the risk, and you have to write your reasons down. To the best of my knowledge, this next thing I'm about to tell you has not been specifically researched with the level of service case management inventory, but what we know is on the adult side that when you are assessing risk, the more you allow your evaluator to depart from the four corners of the tool, the less reliable the tool becomes. Clinicians are terrible at unguided risk assessment, and they are often tempted to insert their judgment as an override over the tool, which would be lovely if the data suggested that improved the reliability. It ordinarily sharply deteriorates the reliability, at least on the adult tools where they've looked at this question. And your assessors should know that. Yeah?
I just wanted to agree with you. We use that tool, and so we have a policy. We actually don't allow our clinicians to do the override, and we had it validated, the inter-assessor reliability and validity, and the fact that we have a policy that says you cannot. The researchers found that we were using the tool in a reliable way. So it's good to hear you say that.
Yeah, no, it's good, I think, to just sort of say this. I sort of call it and sort of let the chips fall where they may, because there's so much subjective bias that gets introduced into clinical reasoning. I mean, one of the nice things about clinical reasoning is unless you are incredibly precise and disciplined, you can talk yourself into almost anything that your gut is telling you, which is backfilling intuition in the guise of science. It's not actually. I didn't get to all of the questions. I apologize. I hope it was useful. The other thing that I would urge you to do, somebody asked specifically about the issue of screening and assessment tools and race. Many of them that have been validated on multi-ethnic samples. If your population was not in that sample, this may be a good opportunity. Although I'm usually not a big fan of homegrown tools, it may be a good opportunity to work with somebody who's culturally competent and linguistically competent with that particular target population, and to devise something that you can, and then the next step, which is very important, is to then crosswalk its validation with the other tools that you're using to make sure that you're actually getting what you want from your homegrown tool. The MacArthur Models for Change has a monograph on screening and assessment in juvenile programs, and they do a nice sort of discussion of the tools. Short form, I actually like to mix these. One of the reasons I like to use the MAISY is it's well validated, and because so many jurisdictions are using it, I can then compare what's going on in my jurisdictions with other jurisdictions that are using the same tool. I like to mix and match it with the GAIN short form, the SS, and I also am urging folks to explicitly build in a trauma tool, although MAISY does pick up on trauma. And to the greatest extent possible to use a trauma tool that will pick up on the sub-threshold, sub-PTSD kind of adaptations, and because those are really important to understand in kids with high trauma histories. Thank you all.